Our next speaker is Dr. Rachel Burt, and she is the group leader of the Molecular Hearing Laboratory and a senior research fellow at the Murdoch Children's Research Institute based here in the hospital. Her team and herself are working on a congenital deafness study, which is providing genomic sequencing to infants picked up through the newborn screening here in Victoria. This is a pilot program and it's been funded by the Melbourne Genomics Health Alliance, and she's going to explain a little bit more about it. Thank you so much.
Hello, I know you've all been sitting for a long time, so I'll try not to talk too much, but I'm actually really excited to be speaking about this project on behalf of our team. There's a lot of people involved in this project here in the hospital. It's the first time I've actually been able to talk about it in public, so it's really nice to be able to speak to people who might actually benefit from this research in the near future. So the project I'm talking about is called the Deafness Flagship project, and it's being funded through this organisation called the Melbourne Genomics Health Alliance. And as we go through, I'll tell you more about that. That way. Some don't need to tell you this, but congenital deafness is actually really prevalent in Australia and worldwide. Here in Australia, about 1 in 1,000 babies are picked up as being deaf at birth. Here in Victoria, in our state, it's about 60 to 70 babies every year are detected as having a hearing loss at birth. It's a really important thing to detect early, and we've improved in that over the last few years. And being able to pick it up early means that we can intervene and correctly help children with hearing impairment to actually live the best lives that they can. The reason that we've improved in picking up babies early with hearing loss is through this program here called the Victorian Infant Hearing Screening Program. And we now detect 99% of babies with a hearing impairment within a couple of weeks of them being born. That program commenced in 2005, and we now have statewide coverage. So every baby born in Victoria, almost every baby born in Victoria, gets a hearing test within a couple of weeks of birth, and most of them within a few days. This is actually Joseph, who is the baby of one of the clinical geneticists who's actually working on the Melbourne Genomics project, and people will tell me now, but he passed his test. But it's a test that's called an automated brainstem response test. We're actually picking up brain waves in response to sound through that gear that gets stuck on their head. The problem that we still have, or the challenge that we still have, is that although we are able to tell parents that their baby has a hearing impairment, we're often not able to actually tell them why. And there are ways that we can figure out why a baby is deaf, but until recently we really haven't had the technology to do this cost effectively and efficiently, and so that's something that we've been really aware of for a long time, but it's only just in the last couple of years that we've had the technology available to us to really do much better genetic testing for babies who are born deaf. Part of the reason for that is that deafness is not just one condition, it's all very aware. It's a very broad spectrum of causes, particularly genetic causes for hearing impairment, and it's been really hard to test for all of those easily. This is a little breakdown of all the different types of deafness that we can detect. So we know that of all of these babies that get given the diagnosis of deafness, about half of them have genetic causes, and then the other half are non-genetic, or we don't really know what's going on. Of those people, or those children, about a third of them have a syndromic type of hearing impairment, so they're not just deaf, as we should say, there are other symptoms as well. And the other group has deafness alone. And then of those children, there are lots of different ways that their deafness can be inherited, and there's a single gene that causes a large proportion of those called connexin 26, or what's also known as DKB2. So up until recently, that's the only gene that we've really been able to test for routinely for children in Australia. So it's a single gene test. A lot of people don't even opt to have that test done. We're not really sure why that is, just the general community of clinical support groups haven't really been offering that widely to people. So a lot of people children and families who don't get any genetic testing done at all. And if they do get any, all they get done at the moment is a single gene test. There are some more early adopters of modern technology in other parts of the world who have been doing gene panel sequencing for quite a long time now, or at least within the last couple of years, and they test for about 109 deafness genes, and the Usher genes tend to include in those panels. Again, that requires parents to be advocates for their children and to really seek that out in Australia at the moment, and it's a user-paid system as well, so families actually have to pay to have that testing done a lot of the time. What we have now is the ability to actually look at every gene in the genome using exome sequencing. It's been around for a little while now. The technology has been used in the research context, so members of families where deafness is segregating through the family have been able to get access to exome sequencing, usually because scientists have been interested in knowing what the genes are that are causing deafness. And then also in a research capacity, some families have been able to access whole genome sequencing, where we look at the entire genome, so all the bits of DNA in between the genes as well, which is some cells. But this hasn't been rolled out as a clinical diagnostic test really anywhere in the world. And this is what we're actually going to be offering families over the next 2 years, exome sequencing as a diagnostic test. And the reason we're able to do that is because lots of other people have also recognised that this is a really powerful technology that we should be using to help families get diagnoses, not just for deafness, not just for Rett syndrome, but for all kinds of genetically inherited conditions. So all of these groups in Victoria have banded together and have lobbied government and been given some money to actually assess the efficacy and utility of exome sequencing as a first-line clinical diagnostic test that babies can access in hospital right from the very beginning when their doctor suspects things going on. So the aims of this project are to really assess the use of this genomic technology in day-to-day clinical practice. We want to know whether it's actually acceptable to families to have this test, what's the uptake of people actually want this information, how is it used by clinicians to then change the way we actually treat and manage particular children. And we also need to actually integrate a whole lot of new practices and processes in our hospital to actually be able to deliver this test effectively to families and actually give them the support to understand what the test is and the information that they've been given and how that's going to be useful. So we're hoping that what will come from this is that we'll be able to diagnose children very early and give them an access to the cause of the condition that they have. We hope that that will lead to early intervention in a lot of situations. It will hopefully decrease the number of tests that particularly children have to try and get a diagnosis. And as a result, it will result in a decrease in the cost that we have to outlay to actually diagnose children. We'll be using this new technology to do that, and we hope that we will lead to this concept of personalised medicine. So rather than just giving a diagnosis of deafness, you actually get a diagnosis of Usher syndrome right from the very beginning, and hopefully that will be helpful to families. So, I don't really need to go through all of this, but the idea is that what we're going to do is sequence all of the genes, the coding bits of the DNA of actually genes. And to do that, in the first phase of Melbourne Genomics, we actually recruited patients coming into hospital with rare childhood syndromes, colorectal cancer, so these are adult patients obviously, people with inherited neuropathies, acute myeloid leukemias and focal epilepsy. So this work was actually done over the last 2 years. It's been incredibly successful. And it's led to a dramatic increase in the number of patients who have been given a diagnostic cause for their condition, a genetic cause. So this, in using the traditional standard of care, we've been able to go from a diagnostic rate of about 14% up to a diagnostic rate of closer to 60% just by delivering an exome sequence result to those families. So in this next phase of the Melbourne Genomics project, we've been really lucky to actually get a flagship for deafness funded as well. So in this second phase, we're going to be recruiting patients with congenital hearing loss. There are also projects for complex care cases, children with immunological conditions, dilated cardiomyopathies and advanced cancers. We're actually really lucky that we've been selected as a group to be able to test and implement this type of genetic testing. So over the course of the next 2 years, a total of 800 patients will be offered exome sequencing, and 100 of those will be deaf children. And part of the reason why we've been able to access this funding from Melbourne Genomics is that we had a pre-existing program that some of you might already be aware of called ViCCHILD. That stands for Victorian Child with Hearing Impairment Longitudinal Databank, which is a really mouthful. But what it is that all of the children who are detected as having hearing impairment in their initial hearing screening hospital have been invited to join this longitudinal databank. And we've been running for a couple of years now, since 2012. And we've managed to recruit 500 families already into that database. And it just goes to what sort of you said this morning, that by having information from all of those families, we're actually in a much better position to actually run clinical trials like this exome sequencing trial. And it also means that we're able to track kids over a really long period of time and look at their educational outcomes, look at the services that they've been able to tap into, and try and offer them better support and a community to tap into as well. So the ViCCHILD program is allowing us to actually recruit children into the Melbourne Genomics project. So the way we're doing that is every baby that's eligible for the Melbourne Genomics project will be sent this opt-out letter, which I don't expect you to read. But as part of this one-stop shop we're trying to provide to families, they'll be invited to attend a clinic either at Royal Children's Hospital or at Monash or at Austin. And we're hoping to provide better support for children with hearing impairment through those clinics. We are also going to invite them to participate in the ViCCHILD project and also in the Melbourne Genomics Health Alliance project. And parents are able to just come to clinic if that's all they're interested in. They can participate in ViCCHILD and or in the Melbourne Genomics project as well. If parents opt to participate in the Melbourne Genomics project, they're going to be offered 3 different choices in terms of the actual genetic test that they're given. So all of the babies will be exome sequenced, so we'll generate a sequence for all of their genes, but we'll only analyse the sequence in choice A from genes that are known to cause deafness. There's about 100 on our list. Parents can then also opt to have the laboratory actually look at the sequence of other genes that are known to cause childhood illnesses, but that also have some kind of intervention available if they get that diagnosis. And then another list that they're able to have analysed are genes that are known to cause a childhood onset illness, but that at the moment don't have any known treatment. So we're actually interested in knowing what parents choose, what they actually want in terms of a diagnostic test, and whether that information is actually useful to them and is it useful to the training clinicians who have that information as well. So obviously, the Usher genes are included in those lists, and the Usher genes, there's lots of them, as been discussed already, are all included in this study. So we suspect that we might actually detect at least one baby over the next 2 years that's got Ushers and possibly more. So just in summary, we're hoping that we'll be able to get a better idea about what types of genes are actually in the Victorian community that are causing deafness, because up until now we haven't really been systematically testing anybody. So it will give us a much better sense of what they're actually using in our community. We'll hopefully be able to streamline the care of children with hearing loss by really marrying the clinic with Burt and research, and hoping that that actually provides a much better solid base for parents to actually come and get information and good support. We're hoping that we'll be able to get a much better handle of parents' interest in this type of testing, and Do they actually want it? Is it useful? We will also want to know whether actually genomic testing, part of the broader aim of the genomics project is to look at whether it's a useful test to actually use as a screening tool for the entire community. There's lots of screening tests that are already done for babies, and can we actually add enhanced sequencing in as a screening tool for the whole community? And again, the project will give much more information on the feasibility of actually rolling this out in a clinical setting and not just in a research setting. And I'm really here on behalf of all of these people here who are the drivers behind this genomics project, and it's really been a long time coming. It's something that we've been aware that we needed, or that we suspect that the community needs, and so all of these people have been really instrumental in getting the funding and getting the project up and running. I have to really specifically thank Lillian Browning, so she's the mum of Joseph, who's having his little hearing test, and she's doing a master's project at the moment. She's really driving the recruitment of the family. So, thank you. I'm happy to take questions.